Hello, 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 everybody. Welcome, welcome, welcome. Today, our guests are Dr. Tessa Novick and Michelle Osuna-Diaz, PhD, and we are going to talk about some specific issues in disparity in healthcare, namely kidney delivery for people experiencing unstable housing, social needs among dialysis patients, particularly food and housing insecurity, lack of transportation to the doctor's appointments and to dialysis, running errands, affordable house care, and daily needs. So this is going to be one interesting broadcast. Dr. Tessa Novick, MD, MSW, MHS, is a nephrologist with a primary clinical interest in caring for people with kidney disease who come from marginalized populations. Originally a Texas native, Dr. Novick grew up in North Dallas. She's a proud graduate of the New York University, where she attended a bachelor's and master's degree in social work. She's had previous experience working with people experiencing homelessness and individuals experiencing substance use disorders. She ultimately became a physician to combine social work and medicine by addressing the medical needs of people with complex medical issues in their environment. Dr. Novick earned her medical degree with honors at the University of Texas Southwest Medical Center in Dallas. She completed a residency in internal medicine and a fellowship in nephrology at Johns Hopkins. During her time in residency and fellowship, she was known for her professionalism, her work, her ethics, clinical skills, and resident teaching. Dr. Novick's research training includes a Master's of Science in Epidemiology from Johns Hopkins University Bloomberg School of Public Health. Her research interest includes disparities in kidney disease, social determinants of health, and improving care delivery for marginalized people with kidney disease. She is particularly interested in immigrant populations with kidney disease, pain medications, and the impact of housing on the clinical outcomes of kidney disease. Her professional affiliations include the American Society of Nephrology, the National Kidney Foundation, the Renal Physicians Association, and the Travis County Medical Society. Dr. Novick has won many awards for her work, including the Delta Omega Honor Society in Public Health from Johns Hopkins Bloomberg School of Public Health in 2019, an international scholar from the Philanthropic Educational Organization in 2013, the Aloha Omega Aloha Medical Honor Society from UT Southwestern in 2012, the President's Volunteer Service Gold Award from UT Southwestern from 2011 through 2013. Our other guest is Michelle Osuna-Diaz, PhD. I had the great pleasure of meeting Michelle at the Kidney Action Summit for the American Kidney Fund in May of this year. Michelle is a doctor in psychology who graduated from the University of Puerto Rico, Rico Pedres campus. Ms. Osuna-Diaz holds a BA in criminal justice with a major in forensic psychology and a minor in law and society. She also pursued a master's in social community, psychology, and postgraduate certification in not-for-profit business administration. Ms. Osuna-Diaz worked as a research assistant, research coordinator, program coordinator, supervisor, program evaluator, and finally director in different settings, but mostly in academic and nonprofit organizations. She has also taught math, science, and history for 5 years at two mostly Hispanic population charter schools in Austin, Texas. Ms. Osuna-Diaz works to make the community academic connections and also co-developing an intervention to address social determinants of health in dialysis patients and high-risk populations prone to develop chronic kidney disease. So today we're going to talk about social determinants of health that affect kidney patients. Please give a warm welcome to Dr. Tessa Novick and Michelle Osuna-Diaz, PhD. Ladies, how's everybody doing today?
Good. Thank you for that introduction, Uncle Jim.
Yeah.
That was wonderful.
My great pleasure.
Great.
I'm the dumbest guy in the room, so I have to be nice to everybody.
No.
All right. Let's start with Michelle. Did I state everything correctly in the introduction?
Yes. I actually one of my passion is to work with community. That's why I did a master degree in social community psychology, and that was my path. That has been my path from the past 13 years, actually. So I'm so excited to share what we have been working here in Austin, Texas.
Excellent. Dr. Novak, did I state everything correctly in the introduction?
Yes, you did. Yes, thank you.
Great. Great. Let's start with Dr. Novak. Please tell us a little bit about where you grew up, your education experience, and your employment experiences.
Um, well, I grew up in sort of all over the country. I was born in the DC area, lived in California for a little bit as a kid, and then, primarily in Texas, but spent a good half of my life on the East Coast for college and training. Um, and yeah, you outlined sort of my educational experience, and since I completed all of my training at Johns Hopkins, I've been here at the University of Texas at Austin. Um, Prior employment and experiences as a social worker were at a housing facility for adults with HIV experiencing homelessness, and at a substance abuse methadone clinic in New York City. So, kind of a broad range of experiences.
Very good. Very good. Michelle, please tell us a little bit about where you grew up, your educational experience, and your employment.
Of course. I grew up in Puerto Rico, mainly in the metro area. I am a second child from third in a middle class family, in Hispanic family, mixed races. My mom is African Caribbean. My dad was white, from Puerto Rico. Since I was a little kid, I grew up in a mixed family, but in my island, that's kind of normal. But at the same time, I experience racism, right? Since my childhood until I grew up and knew that was a thing that has a name, right? Then seeing certain kind of behavior from people who were treating you when you're a child and you grow up, it marks you, right, in your experiences in life. And then I think that was what my path start off. And my education, I wanted to study psychology to understand behaviors from the people surrounding and society. My main reason was to fix things, but I started to learn that one of the things in individual in psychology, right? Most of the things are socialized, is a social pattern or is a social behavior or are social norms. So I started to think that maybe my path in education were more into social community psychology instead of clinician. I wanted to embrace the social justice and try to see if I can help inequality in any society that I am, specifically with a vulnerable population, right? And then I moved here to Austin 8 years now. I started working as a teacher here in Austin because it was hard for me to find a job as a doctor, believe it or not. But then I applied for a position in UT, and Dr. Novick, I guess she get in love with me.
Yeah, you can see why, right?
And then we started working together. I think that we are very aligned in our values, and I am very happy and grateful to meet her and to work with her. Before moving here, I was working, as you said, in different community organization, and I was also a director in a shelter for domestic violence, women and children in Puerto Rico. And I think that that was always mark my life into see how we can, with our work in the society, be better, like how we can switch or change things that it's happening that it's not supposed to happen in our social life in our work. So that's my story.
I think
Okay.
both Michelle and I have seen and kind of experienced a lot of injustice and the fact that certain things are just not fair. And so a lot of our work centers on um, figuring out, what contributes to that, whether it's individual factors or social factors or societal factors, and, kind of seeing how what we can do about it. And people with kidney disease are particularly affected by a lot of injustice. Um, and finding a way to address that, to kind of facilitate healing and transformation and metamorphosis as a human is really important to both of us.
Doctor was anticipating my next question, so I'll go to Michelle.
Oh,
Please,
sorry.
please talk to us about how you first became involved with disparities in kidney disease patients. How did you become involved with those of us that suffer from kidney disease?
To be honest, I knew about a lot of injustice in a vulnerable population, specifically with Hispanic and Afro American here in United States. Well, we live in Texas, right? I didn't know about kidney, the importance of the kidney until I meet Tessa, actually. Dr. Novi showed me with her work how difficult it was for people who were in dialysis and their conditions and their social determinants of health. How difficult it was for them to pass through this treatment and their social life. But later on, I learned a lot, I think, for not being a physician or a nephrologist about the kidney, the importance of the kidney, and then how to keep it healthy. And then I think that I spread into my friends and my family the importance to check that. And right now, my mom and my brother actually, they both have a chronic kidney disease in early stage. So they are taking care of them. The thing is that when I started with her, we start specifically with a prevention intervention with a community health worker among people who were at risk with Latinos. And during that time, I learned how difficult it was with people not even in dialysis, but who were at risk to maintain a healthy stage or to have education or information about the importance of the kidneys, right? And then how other condition or chronic condition like diabetes and hypertension or cardiovascular disease can also be detrimental for the kidneys and later on to suffer a renal stage that it takes them to dialysis. And among of them were at that time that I met them having problem because they needed to work a lot. They didn't have a health insurance. They couldn't go to a primary care to see how their hair was. And then the food insecurity also were so high among them, and not having a stable house or housing. It was also part of the things that were adding more stress into their health, and that's how I get in this.
Dr. Oh, I'm sorry. Michelle, did you finish?
Yes.
Bad, Uncle Jim. Dr. Novick, do you have anything you want to add along those lines? Why did you first get involved with kidney patients?
Well, to be honest, I did not anticipate becoming a nephrologist when I went to medical school. I just kind of fell in love with the science. To be a doctor, you have to be a scientist as well. And I did fall in love with all of the various aspects of the kidney. I think it's the most interesting organ in the body, but I always wanted to work with, kind of use my social work talents and work with people and treat them as the whole person. And, social workers really treat the person in the environment. So that's really a critical component of social work. So that I wanted to kind of extend that to medicine. And then kind of throughout my training, it became pretty clear quickly how important the environment is for health, but also especially for people with kidney disease, especially for people with kidney failure. So what we see over and over again, and I know you talk to a million people as well, Uncle Jim, and you probably hear this story. Unfortunately, 66% of dialysis patients don't know they have kidney issues before they start dialysis. So a lot of them are working. It disproportionately affects people who are working lower wage jobs, who might not have savings, who might not have support, social support. So they start, and then those types of jobs are not conducive to dialysis. They're less understanding than, say, like an office job or something that requires a higher level of education. And they're forced to stop working, and that leads to substantial just financial resource strain. Cost of housing and living is increasing all over the country. It's a huge problem. And if you can't work and you're spending your entire week at dialysis, and then you're spending the rest of your time recovering from dialysis, then it's impossible to support yourself. And over again, we see people, jump in and out of homelessness because of this experience. And it's a spiral that is impossible to get out of without substantial family support or social support. So if you have savings, if you have a lot of support, I'm not saying it's easy, but if you don't, it seems like it's not going to happen. So I kind of, and not in addition to the social needs aspect, social workers do a lot of mental health support, and mental health concerns are really big in all people with kidney disease. We see the two go hand in hand. So I'm kind of drawn to that aspect as well. The significant impact it has on someone's mental health, and then how that impacts their motivation and treatment and all of their social relationships, really. And we see a lot of people who are very lonely and don't really have any interactions other than those that they experience at the dialysis facility. There's such a really a terrible thing that kind of happens spiritually, I think, when someone's really sick. Why me? Why? There's a lot of self-blame. There's a lot of why me, not them, that sort of thing that goes on, and questioning. And it's just the whole thing kind of breaks you, kidney disease. And, you know, for some reason I was drawn to that. So I just think there's a lot of work to be done. I really care about this population, and specifically the housing piece I'm interested in, because I worked in a homeless shelter. And, since the 80s, or the concept of housing as part of healthcare is not new. We've been providing housing as part of healthcare for certain populations for decades. HIV is an example, substance abuse, mental health. And, it kind of became very clear to me that housing, kidney disease is another population that would greatly benefit. Everybody needs a home, but in particular, this population is very, very vulnerable. So it's kind of been a longstanding mission to advocate and try to get housing benefits, particularly for people with kidney disease. But there's just so much to it. It's not just about the kidney. It's also about the trauma that people experience when they don't know that they have kidney issues, and then they're suddenly hooked up to a dialysis machine in the intensive care unit, and the questioning that goes with that, and the anxiety and the panic. And I think that we could do a lot better as nephrologists. We're really good at addressing the science, and it's a very exciting time in nephrology. We have lots of new medications and genetic testing and phenotype abilities, and we're transplanting pig organs into humans, and we're doing a lot of cool stuff, but we are not, we're still kind of saddled with the fact that kidney disease disproportionately impacts people who are Black and brown and populations of color, and people who with lower socioeconomic status who have no access to all of the exciting advances that we're seeing. And that's a big problem. And it's multifactorial. It's not just access to care, it's all sorts of things that contribute to it. So I think, it's always been my mission to promote the social work model, addressing the person in their environment. There are a lot of movements in medicine trying to do that as well. Integrative medicine. There are a lot of groups trying to promote that, but we need to do things a little differently.
I think this is a condition in human that it cannot be just treated for one side of a science. Like nephrologists are important, and their education are important to help people with these conditions, but it's a multi-sectorial, and it needed to be a lot of integration of professional to work with this, because it's not only a condition with an organ, it's also coming from before that. I always said that most of the people who ended in dialysis, unless they have a genetic condition or something in their life path happen that were detrimental for their kidney, but a lot of things happens, and there's it's the ending of a lot of social determinants of health, a lot of social injustice between people who are Black, brown, Hispanic people, who doesn't have the same resources or opportunity than others in the society, like education, perhaps. I think that if we promote better education in health, no matter how we are, brown, pink, white, I think that it will be just a little step to help us, because we all live in society, right? And then this is a condition that it takes money from everybody. Those who doesn't have it, it's very hard to pay for it, or to have access, as Dr. Novi said, for the last technologies or medicines that we can have for this condition. But also, the people we pay taxes, it's a lot of income that goes through when you already have the condition to take care of it, right? So it's something that everybody should be worried about, not because you have it only or your family has something like that, but also the people who doesn't have it need to check on this, because it sadly impacting the society in the whole, not just the people who suffer it.
Okay. Let's go to Dr. Novick for a minute. Doctor, please describe for us your experiences with immigrant populations and kidney disease. What are the kidney issues that you have encountered there, and how were you able to help and resolve those issues?
This is just a devastating situation right now, especially in Texas. So, well, first of all, my grandparents were immigrants from Ukraine, and we know based on generations of data that the skin color of immigrants affects their future generations. So I am able to be a doctor and own a house and was able to attain an education, and that is largely because of my skin color. So, I've always been interested in kind of that difference, and unfairness, basically. But what we see here in Texas, so for example, we have a large population from Mexico here in Texas, and the prevalence of chronic kidney disease is actually it's higher, but it's relatively similar for people in Mexico. A lot of, risk factors might be different, but what we see despite that is their risk of kidney failure is much higher. So they progress to kidney failure more often and faster than other individuals. And it's just devastating because I see people in clinic, and, again, we have a lot of great medications right now to treat diabetes and obesity and high blood pressure. And a lot of people can't afford them. They don't have insurance. They can barely afford to see me. And then, I'm sort of at that point like a fortune teller. I can't really offer them anything to fix what's going on. I can just kind of tell them what's going to happen. And that's the people that I do see. A lot of people where we don't see until the very end. So they don't know anything about their kidneys until they show up in kidney failure at the emergency room, very sick. And in Texas, we can't even offer them standard treatment for dialysis or standard treatment for kidney failure. So they are not eligible for standard dialysis or kidney transplant. And a lot of these individuals are young with lots of, with kids, and they're trying to support families, and they're doing the best they can. And it's just devastating, and they die. And we know that mortality is 14 times higher for people who get emergency only dialysis compared to standard dialysis. It's expensive on top of that. So people are dying. They're being admitted to the hospital just for dialysis because they can't get it in a clinic. That's a very large expense, and it doesn't work. It's terrible dialysis. It's unethical. It's forcing the nephrologists and physicians to provide care that is not what we were trained to do. So it's another example in Texas of how politics is telling me how to do my job as a physician, despite my extensive training. And it's basically limiting my ability to do a good job. And people are dying, and we're seeing consequences of that. And it's devastating for many people, many populations, many families. The children we know of, their parents who, if they get emergency only dialysis, are so traumatized. A lot of them feel like they, and speaking to them, people have done documentaries, etc. They end up staying home from school because they're worried about their parents being sick and they feel the need to take them to the hospital. It really impacts the whole family, where it's the whole population that really is suffering from this. And other states have found a way to do this, to provide better care, such as California, Colorado, New York, Illinois. There are other states who are doing it better. But it's a political issue, and it's really, people are suffering and they're dying as a result. So that really keeps me awake at night. And a lot of some of my work is to kind of tell the stories of these individuals. So we've done a couple. I've done a couple studies, qualitative studies, to kind of capture their experience, but also it affects the whole system. You get nephrologists who don't want to work in Texas, and it's completely understandable because we're being asked to practice unethical care for this one group based on a political opinion. And that's really what it comes down to. And it's infuriating. And the moral injury associated from that is really, really high. So, just trying to capture the experience and do what we can to provide the evidence base to support the fact that states like Texas need to change. We need a national policy for kidney care for immigrants who don't have access to insurance, bottom line.
Couldn't agree more.
Yeah.
Couldn't agree more, my friends. Let's talk a little bit about the social needs of dialysis patients that the two of you have worked with in the affected populations. First, with Michelle, what is your description of the social needs of dialysis patients that you have found in the course of your work?
Yeah. Well, at the beginning, when I started with Dr. Novick and just interviewing dialysis patients to see what was their social needs, without starting a intervention with how to address those social needs, right? It was kind of interesting to see people at dialysis not having time. Those people who could work, not having time to work, because it was 4 hours approximately every 3 days out of a week. Which is kind of difficult to find that flexibility in a work for you. The other things, so that means that the people who are going to dialysis will not have money to sustain themselves or their family. The other part was people who were living in another houses with other people, maybe in rented apartments, and they were living in the living room because they didn't have opportunity to rent in a space that they can be comfortable in one room. So we say that maybe they were living in overcrowded situation without a space. The other things that we have been looking at is a lack of healthy food, but those things comes from the beginning, probably before being in dialysis. Most of the people in dialysis need a specific dietary, and it's almost impossible for them because of the economic situation that they present. Even if we apply with them to have a SNAP, which is the card that the government provide for you to buy food, the amount that they give to the person is like 125 approximately per month, which is kind of difficult for them to find out something that they can eat appropriately for them to be healthy, right? So what they're going to eat, probably they're going to eat something that continue being non-healthy food, which is going to not be good for them in their treatment, right? And you can see the consequence of that in most of our patients. The other things that we see is like they cannot afford to pay certain medications, right? Like most of them has um, hypertension or diabetes, or they need other medication for lupus or any other conditions that they have, and they need to select what to choose, right? Which one they need for that time, which one they can pay or afford, because they don't also have the money to pay for it. Most of them actually, after when they start, if they have a job, they lose their job, and then at the beginning you can see they have a health insurance that can help them because they come from what the health insurance that they had at the work, but then it doesn't cover anymore, and you can see a gap in a being stable economically and then going into I say poverty in dialysis, where they needed to really be in a point that they're touching the ground economically for them to apply for affordable housing or for a SNAP or for to have voucher for transportation and things like that. So you can see when they enter with this traumatic, right, it can be to know that you now need to leave with dialysis for you to be alive, but also you're losing your job, you probably are losing your house, you don't have more money to be the household in your life, right? So everything go down for most of them, and then of course emotionally and psychologically that impacts too. In the transportation area, we know that if you have Medicare or Medicaid, I think it's Medicaid, covers the transportation. For most of them, but they cover the transportation only for dialysis. So you can see the thing that we are talking about in terms of policy. I probably think most of the time the people who make these policies doesn't know specifically what are the needs of these patients, because they need to go to another appointments. They need to go to pay their rent. They need to go to pay to do certain kind of thing, errands, to find out food, to do other things that it doesn't just stand in the clinic of dialysis, right? And then Tessa was saying before that we encounter a lot of patients that are living by themselves. They are really alone. And if, of course, you live in a country that it's very like expanded in terms of territory, and not a lot of people live in the same area that they grew up or was raised, right? So family most of the time is spread, and then we can see that in our patients where they are alone. Their family or new family lives in other states, and they live here, right, in Austin, which is not the shittiest city in Texas, right? Which is everything is increasing and also increasing for the vulnerable population. Like if you wanted to pay a rent right now and being by yourself and being in dialysis, and you getting a disability check, which is only paying $900 per month, how you can afford to live by yourself, right? In a place that the rent is more than 1,500, right? So there's a lot of things that it's not being considered when people are suffering this disease and they are in dialysis. So we're talking about transportation. It's not affordable. It's not even the reality of what they live. We're talking about housing. They cannot afford even to pay rent. Therefore, there are a lot of people living with another person, and then most of the time they are not even their family, or they are living on the street in camp. They cannot afford to buy the food because it's expensive. You don't have money to buy anything else. They need to select or choose what medication they can buy because they don't have the money, or they need to select if they can pay their rent this month, or not paying the rent and then pay for their medication. So there's a lot of struggling in terms of economic that affects them in the treatment, of course.
Okay.
The other thing that we see a lot is the criminal justice system, and how that can impact our patients. You know, I frequently see people who are started on dialysis when they're in prison. And then when they're released, they have no support, no resources. We had one participant in our study who was in prison for 30 years and then released, and he had, you can imagine just the changes in technology over 30 years. It was probably like he was released and, onto a different planet. But, he was experiencing homelessness. He had pretty much no support. There was someone he thought he could maybe stay with in San Marcos, which is like about, 40 or so miles away from us. Took a bus there. That person wasn't there. And then he actually walked back to dialysis in Austin. And, that's just one example. That's kind of an extreme example. But another patient I had in the past, had to do urine tests for his parole officer. And he would, because he didn't make very much urine, he would guzzle gallons of water in order to make a little bit of urine for this test, and would come in very sick all the time. That would basically put him in the hospital. And the criminal justice system did, regardless of the notes that I wrote and letters on his behalf, didn't care and was not accommodating. And, it's just been a battle. But social needs impact people in a number of ways. So we had another woman who had an apartment, but she had no furniture. So she was just sleeping in her wheelchair in the middle of an empty room. And, the stress that puts on the body when you can't recover from dialysis is just devastating. So
we also have a patient that was trying to do dialysis at home, and she was actually doing for 3 years. And she didn't have a person. She couldn't clean the house. For you to have dialysis at home, you need the support, right? And then she couldn't maintain herself in her home, even though that she wanted, and she tried so hard, that she ended at the dialysis center back again, but in the more detrimental conditions, right? So you can imagine a person that cannot clean their house for 3 years, how that can be, right? And we also have people who live with their family, that they need to work. They don't have any other things to hold on, right? They don't have the money to afford this. So I have a patient that the only support person that she has is a son that need to work more than 12 hours. He only have 30 minutes to be with her. She cannot, because of her condition, she cannot be by herself. She cannot cook for herself. She cannot go take a shower because there's no any arrangement for her and her disability. She is in a wheelchair for her to take a shower. So you can imagine how difficult this can be for a person to think, or just to be in a condition like a normal condition when the person is in dialysis.
Okay. Ladies, I want to move on to our main event as far as questions are concerned. I want to start talking about the issue of insecure housing for kidney patients. We'll go to Dr. Novick first. Dr. Novick, can you give us an overview of your research and findings on this subject?
So what I have found is housing and kidney disease are very tightly linked. people with housing insecurity are more likely to develop kidney disease. And then once someone has kidney disease, or, kidney failure, housing insecurity increases the risk of death and dying. And the two, as we've described, it's pretty, the mechanism there is a couple of things. Homelessness and housing insecurity make it very difficult to meet the demands of dialysis. It makes it difficult to recover from dialysis. It makes it nearly impossible to attend any sort of appointment outside of dialysis, to eat the food you need to eat when you're on dialysis. Transplant is completely out of the question. And it's increasing, as cost of living goes up. Disability payments are not being adjusted appropriately. And even if people have a job, frankly, wages are not being adjusted appropriately for cost of living increases. And people are losing their housing. It's happening, and it's contributing to worse outcomes in the groups that are more affected by kidney disease. So again, Black and brown and populations of color and lower income are more likely to experience housing insecurity. This impacts their outcomes. So we have done a couple of projects kind of first describing how this happens. I've looked at several data sets nationwide that have demonstrated worse outcomes for people with kidney disease experiencing unstable housing. We put forth policy recommendations as well, because there are things that communities can do to kind of mitigate this. Like, for example, how we prioritize people on housing lists is actually sometimes racist process, and disproportionately doesn't benefit the people that need it. And we could do things there. We could invest more in affordable housing in communities. We could make it easier to navigate housing programs. So that's one of the things that Michelle and I are working on, is like a community health worker program to help dialysis patients get plugged into the housing system and navigate the housing system. And the problem also is that housing sector and healthcare sector are siloed. They don't communicate. And people with severe illness, serious illness, are more likely to experience housing issues and less likely to be able to figure out the system. There are so many issues, but again, we put forward policy recommendations for treatment. It's kind of something that nephrologists also need to be aware of and address as well, because when someone is experiencing housing issues, they are often labeled as non-compliant, non-adherent. There's a lot of prejudice and quick, judgment toward people who can't make it to sessions. And a lot of physicians and healthcare workers kind of give up on them and dismiss them. And there's just more that we could be doing to address this situation.
Michelle, with your experience with housing issues, why are housing issues a significant factor in kidney health, possibly leading to worse outcomes than people that do not have kidney disease? Why does that happen?
As I think that Tessa had a great point over there. The affordability right now, there's a lot of things that combine together, right? The access for education where you live here in the United States depends on where you live, how to have a better education or not, to have a better opportunity of work in the future, right? Most of the people who live in certain sectors, I should say red area, are more left behind about the system. and they cannot afford to pay their taxes. They have their own probably house that they've been living for a amount of time. Their family lives in the same place, so it's something that happens in the whole complete family. Can be more than 100 year people living in the same way as a family, right? Something that goes through and then it's not, I should not say that this is something that impact only people in dialysis, but the primary comorbid conditions, chronic conditions that affect the kidney, which are diabetes, hypertension, cardiovascular disease, are very linked with people in poverty, right? And those that suffer the most are the people who are left behind, which are the vulnerable people like Hispanic and Afro-American, or a dark color scheme, right? And then therefore in the future, this is going to be an impact to their health, because imagine yourself eating the same food, affordable food that you can eat, because you don't have more money to pay for something that is healthy, knowing that everything is increasing in terms of money, and your income is not increasing. So you are just taking whatever is fixed for you for it. You might not have an insurance, so that's going to impact you also. Well, if you compare another household for other more resourceable people, they can go and buy the food that they wanted for them to be healthy, right? They can have the insurance, so if they get sick, they can go right away to the doctor. They don't have any, the circumstances are completely different. And then when you see these things, of course, it's not only the insecurity of a housing, is the insecurity of everything. That's why it's very important to consider the social determinants of health. It's not only not having food, not having housing, not having education. It's the political system, it's the policy, the social values, the social norms that we have that impact the vulnerable people, that affects their health, right? And eventually they're going to suffer more chronic disease, like chronic kidney disease, and therefore end in dialysis. And then it's an accumulation of social condition that gets to that. But yeah, and I think that especially with dialysis patient not having a place to stay and feel that they can be in peace in their own house, will trying to recover after dialysis when they feel sick, when they feel awful, right? It's very important. No, also with the medications. That person that we have living on the street, he make an arrangement with a person so he can put his insulin in her fridge every day. So he needs to go to this woman's house and put his insulin. And the trick that they did is that he's going to take care of her flowers and her garden. So you can imagine the things that they are living, not just because they don't have a steady place to live, right? And even though that they can rent with other people, still, if the other people stop paying the rent, they're going to be at the street, right? So you depend on others. While you don't have that security, and that's mindset, a peaceful mindset that you should have when you are in a treatment like this.
Dr. Novick, does unstable housing contribute to the progression of kidney disease in the patients that you've observed?
Yes, absolutely. Two ways we suspect. One is kind of the postponement of medical care. We found that people with CKD who are experiencing unstable housing are less likely to attend needed medical appointments. And, again, housing insecurity goes with inability to afford medications and food and participate with, do healthy lifestyle behaviors. We know that the location of the home also matters. So experiencing housing insecurity, certain neighborhoods, for example, are more exposed to uh, just climate injustice, and pollution, which affects progression. Or we're seeing associations with CKD progression and worse outcomes for dialysis patients. We are also the stress and the trauma of experiencing housing insecurity has an impact on glucose levels. And, for example, like we know meditation and deep breaths can lower glucose levels, and stress and cortisol elevation and all sorts of, just the allostatic load of experiencing housing insecurity can contribute to blood pressure control, diabetes control, and therefore kidney disease progression. So yeah, absolutely. It's the environment itself, but also the kind of inability to manage risk factors and kidney disease itself.
I wanted to add quickly, we live here in Austin in the city, right? So if you wanted to have an affordable housing, you might go to the cities around the area. And if you are a dialysis patient, that's hard because there are not too many clinics for dialysis patients in those areas. So they eventually needs to travel to Austin to get their treatment and then go back. In a transportation that is affordable for with the Medicaid cannot cover the miles that they need to take to come over here to take the treatment and then go back.
Michelle, talk to us a little bit. Do people on dialysis or maybe with kidney transplants that have issues with housing, do they also have a difficult time storing and managing their medications if they don't have a permanent address?
Yes. One of the experiences or two experiences that I have with that with two patients. One of them, she lives far away with her mom because of the only way that she can live with right now. She doesn't have money to pay for rent, so she lived there to avoid to pay for rent, right? But she lives far away from another city, and then to come over here, she needs a transportation, and she doesn't have a transportation, so she relies on her sister, I believe, the days that she's available for her to have a dialysis, and she cannot afford her medications because she needs to pay for the gas, right? So for the gasoline, or she needs to pay for the transportation because it's not covered with the medical insurance that she has. And the other person that I have is this person that lives on the street, right? He cannot have all his medication with him, so he needs to have a person that can be reliable for him to stay with his medication in order for him to not lose the medication, and specifically that the one for diabetes, the insulin, right? It needs to be in a place that is cold, cannot be in the environment conditions that he is living. More here in Texas, where he stay outside, we are almost all of the time in 100 or more in temperature. So it's detrimental for him, for his health, and then his condition actually. But not having a housing or live far away from where you need to go to your treatment, it's a really hard condition, a social condition for the people who are in dialysis experiences the need to have reliable places to storage the medication or to pay for transportation, gas, and all that kind of stuff, which eventually is going to be the money that they need for them to pay their medication.
Dr. Novick, this same group of people, as a kidney patient myself, I know that we have certain dietary restrictions. Do these people that have housing insecurity and are kidney patients, do they have difficulty following their diet plans? Do housing issues mean these patients don't have any control over their food?
Absolutely. We have a guy in a study that we did who told us that when he was living on the street, Michelle asked him like, where do you get your food? Um, and basically he said, I would go to places and either steal it, or I would go to restaurants and kind of like eat out of the trash, just see whatever they were throwing away. He had no control whatsoever, but you have to eat to survive. So, that was worth it. And then the same goes with people experiencing, who are experiencing housing insecurity are probably also experiencing food insecurity, and using the Central Texas Food Bank is really amazing. But sometimes they're more likely to eat canned food, which, might have more sodium or um, might not meet all the needs that they have. So yeah, absolutely. That's one of the ways we see housing insecurity impact someone's health is by just limiting their ability to control what they can eat.
Okay. Michelle, we've talked a little bit about transportation issues, getting back and forth to see your doctor, being able to run errands. One of the things that we haven't talked about in a lot of detail, people that have housing insecurities, do they frequently miss their dialysis sessions?
Yes, yes, actually, in transportation too. This person that I talk about, who lives with her mom, she depends on other for her to have a ride to go to the center, right? And she also, we forget about people who have kids and who are in dialysis, and not all of the kids are kids that are, neurological, I should say normal but standard. She have a divergent neurological divergent kid that needs in a lot of attention. So if she doesn't have anybody to take care of the kid, she cannot go to the dialysis. Actually, also there is a like a gap in the transportation relying on the Medicaid or those that can pay the insurance. Actually, sometimes they forgot about their patients and they need to call back. And if they don't have a availability or like a time open in their transportation, then they cannot go pick up the patient. So they miss the transportation just because of another person forgot to pick them up, right?
Oh boy.
Yeah.
It's
This
a
is
doctor.
sadly,
Oh, I'm sorry. Go ahead, Michelle. I'm sorry.
I was saying that it's a sadly way to see things like when you don't have affordable transportation or when you don't have a transportation that everybody can take in a society, and it depends or rely on more a car transportation instead of public transportation. Is hard for people who have chronic conditions like going to dialysis because they cannot rely on something that the city can provide, right?
Nothing like having Reliant ambulance service not show up to pick you up for dialysis or to go have a meeting with your post-transplant physician. That's kind of messy. Dr. Novick, do this same group of kidney patients without a permanent address, it sounds like there's a chain of events that goes on to the point where they eventually lose their benefits or insurance coverage?
All the time. Yeah, you have to have a stable address for a lot of benefits. And, for some reason you have to renew benefits all the time.
Medicaid.
And yeah, and it's just a nightmare. It's really, the system is not set up to help people at all. It's kind of designed to let people fall through the cracks, and it impacts everything.
I think that it doesn't cover the reality of patients in the actual life that we're living. Like we were trying to get a system for a person that doesn't have anybody, and then to have that assistant, we needed to change the insurance, and then that insurance didn't cover other parts of her dialysis, so it was kind of a mess for that. Um, yeah, it's I think that Medicaid and Medicare sadly doesn't know in terms of chronic kidney disease and dialysis patient the reality of what's happening with the social environment and their conditions.
Okay. Dr. Novick, let's talk for a minute about what solutions, if any, may be pursued to help resolve these issues for kidney patients with unstable housing. How do you help these folks?
Well, there are things that need to happen at the level of the community and the provider and the dialysis unit. At the level of the community, we really need to look at our housing programs. Not only do we need more investment in affordable housing, but again, the way we kind of triage people is often is often disadvantageous for people on dialysis. The housing programs themselves often have requirements or characteristics that are not conducive to a healthy lifestyle for a dialysis patient. For example, we have a lot of housing, not a lot, but there are some housing programs in Austin that are too small. The units are too small for home dialysis. The units don't have bathrooms, so people have a shared restroom, little things like that. Or they're often very far away from dialysis units. They're very far away from grocery stores. They are not conducive to promoting health for people on dialysis. The other thing that we see a lot is some housing programs have requirements like you have to be living on the street for a year to qualify for a unit. And frankly, living on the street for a year is deadly to someone on dialysis. They won't make it. So it requires commitment from the community and policymakers to invest in affordable housing programs that are a housing first approach that have realistic qualifications and criteria for people who have severe illness, that are medically appropriate housing. A lot of housing is just a roof, and that's not an appropriate setting. It's not really better than no roof for somebody who is seriously ill. The other thing is just increased awareness. Overt homelessness, living in an unsheltered situation is usually pretty obvious, but we don't always pick up on various levels of housing insecurity. So someone being worried or couch surfing, that's one thing that we don't always pick up on. And we're too quick, again, to not understand how that impacts someone's care. And that we need to increase basically screening and understanding, and to understand the prevalence, and that could affect policy and planning for housing programs, that sort of thing. And then at the level of the individual, the physician can adjust care in a way that is helpful for patients. Like, for example, being ignorant to someone's housing situation and then adding more and more and more medications instead of simplifying, finding medications that are better, longer acting, things like that can be done. I also talk to all of my patients about how to do a diet for dialysis based on food that you can get from food pantries. So, I provide education on what to do if you're relying on canned food, what to do if you're relying on canned food, because that's the reality for a lot of people. You can do things and make adjustments to your diet and still eat canned food and meet your electrolyte requirements. just being honest and helping, address these things also facilitates a better relationship between the patient and the provider. And then also acknowledging the co-occurrence of serious mental health issues that go along with poverty in general, and addressing those, because those, impact treatment just as much as housing, if not more, so there are things that can be done at numerous levels. It requires investment from all of us, the providers and the community.
Okay. Michelle, are there any other possible solutions that can help these patients that have insecure housing?
I think that this is a matter of people living in society that it needs to be addressed with the social policies. Right now, we have a lot of people in this country. It's one of the most a country with diabetes, high rates of diabetes and comorbidities conditions, right? So what we expect, what we are expecting as a society, what's going to happen in 10 years, right? Do we have the social policies to address the needs that's going to happen in 10 years? Not a lot of people are going to afford one or two houses. There are a lot of things that is happening right now in terms of housing that it's increasing. Not even a person that lives in a median a household that has a income of $60,000 to $80,000 a year can afford a house, and it's a middle class, right? So what we are expecting for us as a society in 10 years, I think this is something that we all need to start thinking about and addressing as a society. Perhaps doing a work in the engagement communities, addressing their needs in those terms, and then try to become with more affordable housing, or I don't know what we can do in the market, but it's probably going out of our hands right now, and those are things that we need to control, not because of what is happening right now with people who have conditions like this, but in the future, like what we are expecting as a society, that where we're going to be if our high rates of diabetes, high chronic disease, and high hypertension and or cardiovascular disease are so high. It looks like we're not going to have a healthy society. It looks like a lot of people is going to have a lot of conditions that relies on payment medical bills, right? Which they are also not affordable right now. So I think this is something that we need to address as a society, and not letting people that it's only controlling the policies right now, the government. We need to be involved. We are human that live in the society, and I know a lot of people say, I don't like to talk about politics. We are in a society that works with norms, that works with politics. We need to be involved with that, right? Because after all, who's living the society is us. Those policies needs to be addressing our needs, right? And then right now, we are in a the policies and society are running in a different way, and they are not performing together. They are not linked together. They are not addressing the needs that the society have right now. Right?
I just have one more thing to add,
Sure.
going back to kind of concrete things that we can do. We know based on our research that people who are eligible for Medicaid, dually eligible, are more likely to experience housing issues. And one of the things that we're testing right now is putting a community health worker who is certified to help people navigate the housing system, who can put them on housing lists. We're putting that person in the dialysis unit And so far, our preliminary data shows that actually people do experience an improvement in their housing. So there needs to be someone in the dialysis unit who's dedicated to social needs. And the social workers are dedicated to this, but frankly, they're spread too thin. And I think for dialysis facilities who have a certain percentage of individuals who are Medicaid or dually eligible, there needs to either be more social work support, an additional social worker, or something like a community health worker who can help people navigate the existing community resources.
I wanted to add something on something that is happening right now with some of the patients. Is like, even though that they're receiving a disability check, they don't qualify for affordable housing. I'm not talking about the list of housing at the state. I'm talking about affordable apartments because they have too much money to pay a range for them. But actually, that's not the truth. And another thing that's happening here in Texas right now, at least here in Austin, is that our list for the state housing program has been locked for a year. So we cannot put the waiting list. We cannot put anybody in the waiting list right now. So I think there should be more programs that can be more flexible in those terms, in terms of the state, probably give more vouchers that it can be abroad and to other cities around the area that they can use, right? Because it's not enough. What we have over here, at least in Texas, what we have over here is not enough for us to accommodate people in affordable housing, even if we want it.
Okay. Dr. Novick, let's talk for a minute about the future projects that you're involved in, at least that without breaking confidentiality, that you can discuss with us today. What's coming up?
Yeah, a couple of things. Well, right now we're still working on a study that I just mentioned, where we have a community health worker in the dialysis unit to help people on dialysis navigate community resources to address their social needs. Actually, a couple of future projects to address the trauma that dialysis patients experience and the mental health concerns that go along with that, with kind of alternative complementary methods like acupuncture. So a lot of people on dialysis experience panic attacks during treatment, and they either avoid dialysis completely, or they don't stay on the machine the whole time. And there are things that we're doing with combat veterans with acupuncture to kind of manage those symptoms, and that we could be doing during dialysis to help people kind of feel a little bit better and help manage those symptoms, non-pharmacological. So doing some things there, but really, our work is in the psychosocial space in dialysis or in kidney disease. So addressing food issues is another kind of topic that Michelle and I want to pursue, and again, kind of like the mind, body, spirit connection for people with kidney failure.
Okay. Michelle, what's new, different, or exciting that you can talk to us about?
Well, I'd like to involve people in the society and community, and something that we did and we are trying to continue with it. This was a kidney community advisory board where we bring people from a community in different spaces, including another foundations, organization, even state agencies to work with us in a different scenarios. And right now we are doing more community engagement with actually right now it's with the National Kidney Foundations, and also a community like churches where we go and with the National Kidney Foundation's services, we go and do prevention. The last weekend, 2 weeks ago, we went to the consulate, Mexican consulate here in Texas, and we did an event like this where we are bringing people who can measure the high blood pressure, BMI. We were doing a urine analysis to see the protein urine, and then they are also giving more information in terms of health, because when people come over here to the events, they're mostly don't have the time, or they don't have the resources to go to doctors, and they actually ask you a lot of questions regarding to their kidney, but also regarding to how to be healthy, right? What things they can do. So I think that is something that we would like to do also, besides to work with the dialysis patient, because for me, dialysis patients have a lot of things that we need to work with for them to be treated equally in a scenario that they live. But also we need to bring more advocacy in prevention and with kidney. There's a lot of days for diabetes, or a lot of prevention for high blood pressure, but we don't talk about what happens if this is not working or doesn't work in your body, right? And then I think that something that we would continue doing is to work in that engagement with the community to bring more opportunities for them to take care, to be empowered of their health. And it probably, this engagement is going to turn into different kind of projects, because when you go to the community, you cannot impose your ideals, right? They have their own needs and they have their priorities, right? And then that's something that we're trying to work to, like giving a participatory empower research to the community, where they can be in hand of what they wanted to be in approach in these matters as they have in the community. I think this is for me, is one of the legacy that we are just putting there in the community, so we can continue working on them to have a better life, right?
Excellent. Excellent. All right, ladies, we are in the home stretch here. Let's start with Dr. Novick. Do you have any final statements that you wish to make today to our audience before we conclude the broadcast?
Just that kidney disease is hard. It is traumatizing. It is not user friendly, and I think that the kidney community, we can do more, I think, to recognize that for our patients, and be more accommodating. I think that we still don't address kind of the emotional, spiritual devastation that someone experiences when their kidneys don't work, and I think that's kind of where we need to go, is really think about how the environment, how all of this is impacting someone, if we want to improve outcomes. And just, I also want to say to all the people out there who have kidney disease, I want to recognize that you've been fighting for your life, and it's traumatizing, and your providers we're not trained to pick up on that. I think physicians are not always the best at addressing that, and just apologies. And I just want to commend all of the patients for what they're doing, what they're going through every day, kind of fighting for their life.
Okay. Michelle, do you have any final statements that you would like to make to our audience before we conclude the broadcast today?
Of course, I just wanted to say that this is something that it's not only a matter of a patient and their families, it's a matter of everybody. I my expectation in life is in live in the in a society that everybody have the same resources. Um, eh, that we can have a better place to live, which is not going to take from anybody, is going to add to everybody, right? And for those Hispanics right now that I am that are living with diabetes, chronic conditions, and even in dialysis, my all respects, I know that their life is very hard when they come over here with a dream, and then sometimes that dreams looks like it's very hard to reach, right? Just telling them that they're not alone. We have a community. Just reach your community, and if you see that there's nothing that it has been done before in your area, just collectively embrace that space, and then try to make groups and advocate for what's your rights. And then you are not alone. I just admire all the efforts that you put in to live in a American dream, and you have a partner here for life to advocate for you.
Wonderful. Wonderful. Well, that's our broadcast for today. I really appreciate you guys taking time to come on and educate us, in particular about kidney patients that have insecure housing and the effect that it has on them, and what, if anything, we can do about it. I learned so much today. I'm pretty sure that our audience will do that. I just wanted to let both of you know that I'm going to be working very hard during this week to make sure that people see the replay. And of course, it'll be available tonight for people that tune in normally when I do my broadcast at 7 o'clock in the evening. So, and I will let you guys know at the end of the week how we did as far as our post reach is concerned, and people that checked us out. So we'll get a little feel for it. But for you to come in today and give us the benefit of your expertise and explain to us about the issues we discussed with kidney patients and housing and immigration and travel, medical care, indifference from your physician. This is just an amazing conversation, and I'm so glad that we were able to broadcast it. And I want you to know how much you guys are both professional, PhD and a nephrologist. I'm very, very pleased that you took time to speak with us today about these issues. I want to thank you so very much.
Of course. Thank
The
you so much for
pleasure is-
having us.
Oh, my pleasure. I have a couple of things to button up with my audience, who's going to be on next and all that sort of thing. But I've kept you for an hour and a half now. I'm going to let you both go. But again, I just want to say thank you. And just, wow, what a terrific broadcast. Just thick with great information.
Thank you for giving us the opportunity.
Oh, no worries. All right, you guys have a good day.
Bye.
Thank you so much. All right, ladies and gentlemen, that's our broadcast for today. Next week is an off week. Your Uncle Jim is supposed to go out of town with the AAKP National Patients Meeting, and I'll be on an airplane next Friday, so not doing a broadcast while I'm on a plane. We're back on again on October 4th with Julie Carlson Hogan out of Las Vegas. She's going to be talking about her work as a transplant navigator for Square Knot, and also about her need for a kidney transplant. So, kidney patient, transplant navigator and potential kidney transplant patient on the 4th of October. So I want to thank you all for listening. Please, please, please share this broadcast. Lots of interesting discussion today that we've got to get out there so other people see it and realize that, there are issues and problems and things that need to be resolved for kidney patients that have issues with housing, transportation, medication, that sort of thing. So I want to thank everybody for checking us out, and I will see you again on the 4th of October. You guys have a good evening and a good day.